Come, my dear. What's your name? Huh? Why you're late? Must come in time, no? Okay, sit down. Okay. Good afternoon. All of you had lunch? Anybody didn't had? Okay, fine. So I'll be taking today's lecture on neck swellings. Okay. Anything you know about neck swellings? Why it is important? Anybody? Why we should study this? Some of you may be knowing my name. Okay. So let me introduce myself. I am Dr. Anil S. Harugop. Okay. I am working as a professor and head of the department of otorhinolaryngology, head and neck surgery. Okay. So that's written ENT, but the correct nomenclature is otorhinolaryngology, head and neck surgery. Okay. So I joined in 1995. Okay. But my UG life started in 1985. Okay. And I joined as a first MBBS student to this college in August 1985, and I was just sitting like you in, of course, in the first three benches we used to sit, and I have a long memories of this college. So since that time, since 85, I am in this college, and 95 I finished my post graduation and joined to the services. Okay, so before joining to MS in ENT, so I worked about 8 months in anatomy. Okay, so, so that is the background of my this thing, and one ground rules. Okay, so let me make it very clear. I'll give another 2 minutes. Okay, so next for 55 minutes, no, so nobody is going to drink water. Okay, if you want another 2 minutes, I'll give. Okay, some of you already know. Okay, aware. If you want to drink water now, only you drink. Okay, and I can sustain 50 minutes, so you should also follow the same thing. Okay, it's not that it is summer and you are all very much tired like that. You are quite younger to me. Okay, by age your age is less than half of my age. Okay, my experience is equivalent to your age. Okay, I got a 28 years of experience. I'm not going to the details of that, but so why I'm telling is you should have little tolerance. Okay, patience. Okay, so no, that is the end of it. Okay, now stop it. I don't want anybody to interrupt in between. Okay, if anybody is drinking water in between, I'll send them out. Let me make it very clear, and that applies to all the classes. At least in my department, I don't know about other departments. Okay, let me be very clear. Okay, so when your teachers are following the protocol, you must also follow the protocol. Okay, now coming back to the today's topic, why we should study neck swellings? What is the importance? Can you tell this yourself? Yeah, you get up second person. What is your name? Others. Okay, you are from which place? Okay, can you tell why we should study these neck swellings? You know, one or two sentences you tell. Hmm? Tell loudly. Thyroid. Okay, we should know about thyroid. Okay, so thyroid, where it is situated? Can you show with your fingers on your neck? Okay, so his finger is going to the midline. Fine. Please. Anything else? Can you tell why we should study these neck swellings? What is the importance? Okay, so it can be in the form of this neck swelling can be in the form of a thyroid enlargement. What is the common terminology used for this thyroid swelling? Okay, goiter. Okay, so this all you have studied the background in your PUC days also. Okay, and in the first MBBS as well. Okay, so the second differential diagnosis is a lymph node enlargement. Okay, okay. Then anything else? Please sit down. How will you classify these neck swellings? Any idea? Please go. Your PG, come. I don't want any UG to come. As usual, you come late only. I don't want any explanation. If at all you have to attend, you should come in time. How will you classify neck swellings? Any idea? Anything from the birth, the child is born with some anomalies. Okay, what it is called? Okay, congenital and acquired. Okay, so I'm just trying to throw a light. Okay, so your thinking process will start thinking about those things. Okay, and any neck swellings, we should try to know, or as a clinician, how to evaluate it, how to go ahead with the neck swelling. Fine. So with this background, so what are the learning objectives of today's topic? Okay. So neck, all of you are aware that what are the triangles in the neck? Yes or no? Okay. So try to recollect your first MBBS knowledge. Okay. So the neck is divided into two triangles mainly, the anterior triangle and posterior triangle. Okay. So next learning objective is what are the neck lymph nodes. Okay. So there are various ways of classifying the neck lymph nodes. Or they are comes under the heading of cervical lymph nodes. Okay. So anybody who can, how will you classify these neck swellings? The lymph nodes, cervical group of lymph nodes. Can you tell? At least get up. Huh? Upper cervical. Okay. Any other way of classifying? Is there anything like superficial and deep cervical lymph nodes? Please sit down. And have you heard of anything this horizontal chain of lymph nodes, vertical chain of lymph nodes? Okay. So these are all given in the subsequent clinical short books. Okay. So we should know about what are the neck nodes. Then I was just telling about when somebody told about this thyroid. So midline and lateral neck swellings. So why we should know? Because there are some swellings which are demarcated in the midline of the neck. Okay, and there are some swellings which are commonly presented in the lateral part of the neck. Then how should we examine the neck? Okay, evaluation of a neck swellings. So those last two aspects are examination and investigations wise. Okay, so evaluation of a neck swelling. Okay, so coming to this, okay, triangles of the neck. All of you know they are classified into anterior and posterior. That is a major division. Okay. So I hope all of you remember it, isn't it? Anterior triangle and posterior triangle. Okay. Again, this anterior triangle is divided into submental, submandibular, carotid triangle. Okay. And muscular triangle. And posterior triangle is divided into subclavian and lateral neck triangle. Okay, so this is the broad division. Okay, anything if you try to divide and study, then we can remember it better. Okay, so the neck is divided into two triangles: anterior triangle, posterior triangle. Okay, again the anterior triangle is divided into submental, submandibular, carotid triangle, and muscular triangle. Fine. So this is the diagram which is showing a anterior triangle. So the borders of the anterior triangle are some books have given posterior border, some book has given anterior triangle. Okay, so according to them, it is the posterior border of the sternocleidomastoid. It forms one of the border of the anterior triangle. Okay, so this is one border. The second border is the superiorly, it is the inferior margin of the mandible. Okay, and the medially is the midline. So this will form the anterior triangle. Okay, anterior triangle is again divided into subdivisions. Okay, and the posterior triangle. So we'll come to this. Okay, divisions of the anterior triangle. Okay, so it can be submental. Okay, submandibular, carotid triangle, okay, and the muscular triangle. Fine. Posterior triangle, what are the boundaries? Okay. Anteriorly is the posterior border of the sternocleidomastoid muscle. Posteriorly is the anterior border of the trapezius muscle. So you can see this fan-shaped muscle, the trapezius. Okay. And the inferiorly comes is the middle part of the clavicle. So you should remember this: the bone above, bone below. Okay, the bone below for the posterior triangle is a clavicle. Okay, the bone above for the anterior triangle, which forms the one of the border of the anterior triangle, is the inferior margin. Okay, of the mandible. So you should remember these two bones. Okay, then the muscle, the two muscles, sternocleidomastoid, trapezius. Okay, so and the whole neck is having the major and minor salivary glands. Okay, so the major salivary glands are what are those? Can you tell? Major salivary glands. Tell loudly. Okay, fine. Okay, please. Good. The parotid gland and submandibular gland, they are called as a major salivary glands. Okay, so why I am asking is there are two glands, two muscles, okay, and the arteries are there, veins are there in the neck, okay. So this has got an application for the various neck dissections, okay. So if you try to study this radical neck dissection, modified neck dissection, okay. So it is in relation to preserving these major salivary glands or removal of the salivary glands, okay. And there are two nerves which will come here. So whether you should remove those nerves or not. Okay. Even the muscles. So all it has got application to the various neck dissections. Fine. So what are these lymph nodes? Okay. So I was just telling about the horizontal group of lymph nodes and the lateral cervical nodes and the anterior cervical nodes. Okay. So in your almost all you have finished ENT posting. Anybody has not done? Some of you have joined, I think, last week, 17 students batch. But rest you have finished ENT. Whether it is no, at least 50% online, offline. Just finished batch yesterday. Okay, fine. So during your posting, we have tried to discuss about what is known as a wider fringe. Yes or no? Okay. So wider ring is nothing but a ring formed by the aggregation of the lymphoid follicles. Okay. And this wider ring is divided into internal ring and the outer ring of Voiders. Okay. So if you open your Dingra textbook, they have tried to given a diagram of the palatine tonsil, lingual tonsils, and adenoids or nasopharyngeal tonsil, tubal tonsils. They are all the components of inner ring of Voidere. Okay. Whereas the external ring of Voidere or outer ring of Voidere is what is that? Horizontal chain of lymph nodes. Okay. It's very simple. You should try to imagine this horizontal chain starting from a submental group of lymph nodes, submandibular, and the buccal group of lymph nodes, carotid group of lymph nodes, preauricular, postauricular, and occipital group of lymph nodes. So this constitutes from front to back, there is a chain of lymph nodes. This is called as a horizontal chain of lymph nodes, and more precisely, it should be called as the outer ring of Voidere. Sometimes they will ask in a five marks question. Okay, Voidere ring. Okay, so you should tell first. Okay, right, outer ring of Voidere, inner ring of Voidere, and all of you will be well versed with the components of the inner ring of Voidere, but you should try to write about this outer ring of Voidere. Okay, so if you write both, then you will be getting about 4 to 4.5. If you just write inner ring, then you are eligible to get 50% of the marks. Okay, so some books have given, some books have not given. So but it is our duty to sensitize you what you are supposed to write it. Okay, because your teachers will be teaching out of their experience, and if you note down, okay, somewhere in the book or in the brain, that's fine. Okay, so what you are supposed to write is, whenever the question on Warder Singh is asked, you should tell about or write about the inner ring of Warders, components of the outer ring of Warders. This horizontal chain of lymph nodes comprises of the various components of the outer ring of Warders. Okay, and here they have written, okay, node of Rouvier. Okay, so this node of Rouvier has got its clinical importance. Okay, so this is the lymphatic drainage for the adenoids. Okay, adenoids are nasopharyngeal tonsils. When these adenoids get inflamed, the nodes of Rouvier will get enlarged. It will get infected. Suppose if it gets infected and separates, then it forms a abscess in the retropharyngeal space. Okay, and that's quite common in children. Okay, and the most common cause for this acute retropharyngeal abscess in children is the separative lymphadenitis of the nodes of Rouvier. Okay, so one of the catchy question maybe in your practical examination, so you must know about. Okay, then this is of oncological importance. Okay, so you should know something called as a level of lymph nodes. Okay, that's all at this point, and this has got a oncological importance. Okay, level 1, the submental submandibular. Level 2 are the upper jugular lymph nodes, which can be anterior to and posterior to this nodes, nerves. Then the level 3 is mid jugular, level 4 is a lower jugular, level 5 is a posterior triangle group of lymph nodes. Okay, and level 6 is a pre-laryngeal, pre-tracheal, and pre-paratracheal group of lymph nodes. And level 7 is in the upper mediastinum. Why we should know about this? Because the head and neck is known for inflammatory diseases, neoplastic diseases, in particularly the malignant tumors. Okay, so whenever there is a malignancy, so these are the act as a drainage sites. Okay, those particular group of lymph nodes will be enlarged. See, for example, all of you know the lymphatic drainage of the tongue. The tip is draining to the submental. Okay, the lateral part is draining to submandibular group of lymph nodes. Okay, if there is a neoplastic condition affecting the lateral part of the tongue, then we'll get a submandibular group of lymph nodes. Okay, sometimes the tumor may not be visible. Okay, it may be on the ventral part of the tongue laterally. So if you palpate neck, one of the particular group of lymph nodes will be enlarged, and it's our duty as a clinician to know where is the primary. Okay, so these will help to know the occult site. Okay, based on the level of lymph nodes, so we can make a rough guess which particular area may be involved, and we go on searching that area. Okay, and if you miss this area, okay, there it is called as a surgeon's graveyard. So we go on searching one area by another area. Okay, if you miss those cases, they are called as a surgeon's graveyards. Okay, so as a clinician or ENT doctor, we should go on searching one by one area. Okay, if the primary is not visible. Okay, and these are called as the surgeon's graveyards. One of the surgeon's graveyard is the ventral aspect of the tongue. Okay, so usually when we open the mouth, the patient will protrude the tongue, isn't it? They will not lift the tongue. Yes or no? When they protrude the tongue, what is seen is the dorsal surface of the tongue. Okay, and if it is normal, you should not just leave there. Tell the patient to lift the tongue. See the ventral surface of the tongue, flow of the mouth. Okay, so these are called as the hidden areas of malignancy in ENT. Okay, the other areas, if we start studying the fossa of Rosenmuller, vallecula, anterior commissure, so these are the other areas. Okay, try to study about them. Okay, it's quite interesting. There are about 12 or 15 areas. They are called as a hidden sites of malignancy in ENT. Fine. So at this point, why we should know the level is these will act as a drainage sites for different primary site of malignancy. Fine. Is it clear? Any doubt? Okay. How will you examine? So this is a picture which is depicting who should stand behind the patient. Okay. And all of you know that at com. Okay. So you should tell the patient, explain the patient. Okay. Take a verbal consent. So I'm going to examine. Okay. If it is paining, you must tell. Those are the instructions you must tell to the patient. Okay. And try to be gentle. Okay. Slightly flex the neck so that the muscles are relaxed. Then we should palpate the neck in a systematic manner. So which I'm going to tell little later. Fine. So this is about, I was just telling about those neck dissections. It can be radical neck dissection, modified neck dissection, selective neck dissection. Okay. So based on those various triangles, if the dissection is pertaining to one particular area, it is called as a selective neck dissection. Okay. And there is one more terminology, extended neck dissection. Okay. So these are the various fancy terms. So don't bother about them. Okay. So you must know there is something called as a neck dissection at this juncture, and these are the various incisions. Okay. What are the midline swellings? Okay. So the question may be what are the differential diagnosis for midline neck swelling? Okay. Starting from here to here, you should go on naming them. Okay. So the previous slides, 5-6 slides, the knowledge will help you. Lymphadenitis submental. Okay. It can be dermoid, Ludwig's angina, thyroglossal cyst, thyroid swelling. Okay. Delphian node enlargement. Okay. And sometimes it can be a tumor from the isthmus of the thyroid gland, or it can be advanced laryngeal malignancy. Okay. So the laryngeal malignancy may come out of the weak areas in the larynx and it may start protruding as a neck mass. And the last one is a suprasternal lymph node enlargement. Okay. What is that space is called? Suprasternal space. Any name is there? Anatomy. The two anterior bord of the sternomastoids, lower end. Okay. And the in the midline you get a superior bord of the manubrium sternum, and there is a small triangle. Anybody? Suprasternal space of. Okay, that's anatomy. I leave it to you. So what are the different lateral neck swellings? So those are the different things. So in the suboccipital triangle, it is mainly the lymph nodes and subclavicular, supraclavicular area. Okay, so it is mainly from the metastatic nodes. Okay, so these are the various sites of drainage. Okay, so imagine just it can be from the kidney or ovaries. Okay, and it can be cystic hygroma. Okay, subclavian aneurysms, cervical rib. Okay, so cystic hygroma is quite common in children. Okay, and anterior triangle, these are the various things. So thyroid, okay, it is a midline swelling, and these are the various symptoms depending upon whether the patient is having a hyper functioning or a normal functioning or hypo functioning. Okay, so all of you know about those things. Various symptomatology of a thyrotoxicosis or a hypothyroidism. Okay, and at this point, one should remember the thyroid swellings move with deglutition. Okay, that is the only point you should remember. The midline swelling which moves with the deglutition is the thyroid swelling. Okay, but it doesn't move with the protrusion of the tongue. Okay, which swellings move with the protrusion of the tongue? Okay, So that I'll tell you later. Okay. So thyroid swelling can be nodular, diffuse. Okay. Again, this nodular can be single or multinodular goiter. Okay. So it can be cystic adenoma or malignancy. Multinodular can be toxic or non-toxic. Similarly, the diffuse thyroid swelling can be toxic, non-toxic, and toxic diffuse goiter can be a manifestation of a Graves' disease, then colloid goiter, others. Okay, and in this colloid, so we should try to know, we should remember about this Hashimoto's decurrence thyroiditis and Riddle thyroiditis. Okay, so these are the various fancy terms. There is a slight clinical difference between these various colloid goiters. Okay, but clinically, as such, there is no much difference. Okay, so clinically, we should try to know, is this midline thyroid swelling is a toxic or non-toxic? Okay, or hypofunctioning. Okay, so based on that, our management differs. Fine. So these are the malignant tumors of the thyroid. It can be papillary thyroid carcinoma, follicular, Hurtle cell, anaplastic medullary, and lymphomas. Okay. So these are the various types of thyroid surgeries. Okay. So mainly three types: hemithyroidectomy, total thyroidectomy, or near total thyroidectomy. Okay. So if you are interested, you can go through this. But right now it is out of confines of the today's discussion. Okay. So you must know there is something called as a thyroid surgery. Okay. Half of the thyroid you can remove, or a complete thyroid you can remove, or a near total. Fine. Coming to this thyroglossal duct cyst. Okay. So developmentally, the thyroid gland it descends, okay, from the base of the tongue, and along this tract, if the cyst is there, it is thyroglossal cyst. Okay. Since it descends from the foramina cecum, which is pertaining to the tongue, and the it descends down into the neck developmentally. So it has got an attachment with the base of the tongue. That's why it moves with the protrusion of the tongue. Fine. That is the explanation why this thyroglossal cyst moves with the protrusion of the tongue. Clear? Any doubt? Okay. And these are the common locations of the thyroglossal cyst duct, and most of the books, common all books are given. Okay, it can be at the base of the tongue, suprahyoid, subhyoid. Okay, the it can be on the thyroid gland or thyroid cartilage or in front of the cricoid. But the most common location of this thyroglossal cyst is subhyoid. And one point, okay, of importance for surgical management is the systemic operation. Okay, in this we go on tracing the thyroglossal cyst from below upwards. When you reach the hyoid bone, we try to remove the middle one third of the hyoid bone, so that we are ensuring that the whole tract comes out. Okay, and after excising the middle part of the hyoid, we reach the tongue base, and after excision we try to cauterize it, so that the recurrent chances are quite less. It can be in the form of sublingual dermoid cyst, okay, thymic cyst, or branchial cyst, sinus and fistula. Okay, so these are some of the congenital anomalies which manifests as a neck swellings. Okay, so we had about 5-6 cases of this branchial fistula. Okay, and one of the case was the lower end was near the anterior part of the sternocleidomastoid, and it was a small tract which was extending till the base of the mandible. Okay, so we went on excising in a step ladder pattern. Okay, so multiple 5-6 incisions were taken, and the tract was excised in step. Okay, so that's regarding the branchial cyst. Plunging granula. Okay, plunging granula. Okay, it is a pseudocyst. Okay, so what is the difference between pseudocyst and true cyst? Anybody find it out? Okay, so the again that neck swelling can be a carotid body tumor. Okay, it is a painless pulsatile swelling. Okay, so whenever we try to examine neck swelling, so is it pulsatile or non-pulsatile? Okay, if it is a pulsatile one, then usually it has got a origin from the vascular structures. Okay, so this is one of the case of a neck swelling. Okay, and this was the scan appearance. Okay, then this is the angiograph, okay, which was showing the vascularity of the tumor, and this is the tumor mass which was excised, and histopathological feature of a carotid body. I have put it just the pictorial presentation has got a more impression, and you can remember it better. Fine. So cystic hygroma, okay. So this is a lymphangioma or cavernous lymphangioma. So the swelling can be so big like this, okay. And this is one of the uh, CT evaluation picture. So the common in Asian countries, especially in our country, tubercular lymphatics, okay. So we do get cases of this tubercular lymphatics. Uh, Usually they are single, sometimes they are multiple, matted is there, sometimes they will end up with abscesses as well. Okay. How will you evaluate? Okay. So history is most important, how it has started, what is the progress. Okay. Sometimes in the history points, there are points like a sudden increase in the size of the swelling. Okay. Or appearance of new signs, appearance of pain. Okay. Or there are morphological changes over the skin in the over the swelling. Those are all important. So they may be indicative of a existing swelling changing for a malignancy. Okay. So apart from those history points, so what are the four steps? Inspection, palpation. Okay. So those are important. Sometimes we conduct auscultation as well, percussion. Fine. So all of you know those four steps of examination: inspection, palpation, percussion, auscultation. Yes or no? Yes. All of you know these steps? Fine. Okay. So what are the inspectory findings? So in the inspection, we should try to know the what is the number, situation, size, shape, and surface. And the patient is asked to swallow. Does it move with a deglutition as well as protrusion of the tongue? Okay. And skin over the swelling for any presence of these things. Okay. It can be sinus, fistula, ulcer, or scar. So as a matter of fact, they may not ask in ENT, but you should know what is the definition of a ulcer, swelling. Okay. First posting of surgery. Okay. Surgery posting is done. Okay. Good. Then the palpation, the inspectory findings will be should be confirmed. Okay. Are there any differences between inspection and palpatory finding with respect to the situation? Okay. The size of the swelling, then margin of the swelling. The next important point is in the palpation is consistency. Okay. Your palpation should start with is there any presence of tenderness? If the swelling is painful, it's called the pain is a symptom and tenderness is a sign. Okay. If it is a painful swelling, we should be careful. Okay. Our hand movement should be still more gentle. Okay. So the primary idea is you should not cause undue pain to the patient whenever you are doing physical examination. Fine. So after confirming there is no tenderness, then we should start seeing a consistency. Is it firm, hard, or a soft in consistency? Okay. Do you have any idea about this? What is this soft consistency, firm, hard? Anything which is soft in consistency? Hmm? Anybody? Can you tell what is soft in this? Yeah. Okay. Any structure which is on the face, soft. Okay. Lips or ear lobule, that is very soft, no? Okay. So if this consistency, this is soft. What is firm? Okay. Usually the tip of the nose, it is firm in consistency. And hard is a bony. Okay, bony feeling. Please sit down. So those are the similes which are given in our, or they will be discussing in our day-to-day clinical discussion. Soft, firm, and the hard. Okay, are here like this. Okay, and if the consistency is soft, okay, then usually it indicates that the fluid may be there in the swelling, and one should go for a is it are there any pulsations or not, and we should test the mobility. Okay, and if the consistency is softer, then we should try to test for a fluctuation. Okay, then this sentence is for the plane of the swelling. Okay, is it superficial to sternomaster, deep to sternomaster? Okay, that is the mainly one point regarding the plane of the swelling. Okay, then are there any palpable lymph nodes? Auscultation for Brui, mainly it is for the thyroid swelling. Okay, coming to X-ray appearance. Okay, so the X-ray, especially in neck, sorry. So anterior posterior view of the neck, lateral view of the neck. Okay, but for all practical purposes, the lateral view of the neck is important. So this is one of the X-ray which is showing cervical vertebra. Okay, and this is the skull base, mandible, and the upper part of the thorax. Okay, how this cervical vertebra will look on the X-ray? Because these are the various points we should try to see in various conditions. The cervical vertebra, is it straight or has it got any curvature? Normally, it has got a curvature. Okay, so there is a slight bend anterior posteriorly. Okay, so this anterior posterior bending is called what? Clinical terminologies: kyphosis, scoliosis, lordosis. Have you heard of this? Okay, so if it is anterior posterior bending, what is the term? Okay, and this anterior posterior curvature of the vertebral column in the cervical region will be lost. Okay, so there is a smooth curvature like this on the X-ray normally. Okay, so whenever we try to see the lateral neck X-ray, we try to demarcate this smooth curvature of the vertebral column. Okay, and this smooth curvature will be lost, or the cervical vertebra will become straight in case of abscesses. Okay, because the paraspinal muscles, pre-spinal muscles will go into spasm. Okay, any abscess is there, the body how it reacts, it tries to confine the spread of the infection, and one of the preventive mechanism is the muscles will go into spasm. Okay, that's why the vertebra will come straight. Okay, and if you study here, this soft tissue shadow is widened. Okay, so if you open your books and try to see, This is called a prevertebral soft tissue shadow. Normally, the prevertebral soft tissue shadow should be less than 3/4 of the corresponding vertebra. Okay, so the anteroposterior diameter of the particular vertebral column, if you take vertebral body, this prevertebral soft tissue shadow should be less than half of the anteroposterior diameter of a corresponding vertebral body. Okay, so if it is more than that, then it indicates that is a significant widening of the prevertebral soft tissue shadow. Okay, so can you imagine from here till here, it is a almost more than a 1.5 times the corresponding vertebral body. So this is called a significant widening. Okay, so this significant widening signifies a lot of cellulitis is there. Okay, it doesn't signify abscess. Okay, so when you call it as abscess, when there are multiple air shadows like this or air fluid level is there, then we are justified to call it as a abscess. Here, cellulitis widening, okay, pockets of air shadows or else air fluid level abscess, okay. And in case of adults, the common cause for this prevertebral, this retropharyngeal abscess is a cox spine. Okay. So if we study here, the vertebral bodies are destroyed. Okay. Common cause is a tuberculosis of the spine. Okay. So these are the various clinical diagnosis wherein the lateral neck X-ray will help foreign bodies, especially radiopic foreign bodies, acute epiglottitis. There is a particular sign is called as a thumb sign. Okay, retropharyngeal abscess already have discussed. Okay, position of the tracheostomy tube. Okay, so when we do tracheostomy and try to take a check X-ray, will come to just to ensure that the tracheostomy is in position or not. Okay, it will also help for the various traumatic conditions. Okay, compression of the trachea. Okay, especially in case of enlarged thyroid. Okay, there is a compression on the trachea, that's called as a scabbard trachea. Okay. Next investigation is a ultrasonography of the neck. How it will help? Okay. So this is what are the advantages? Okay. So there's some of the points. It is non-invasive, relatively inexpensive compared to CT and MRI. Okay. So they will help mainly for the lymphadenopathy, and this is important. The third one. Okay. So this will primarily help us to differentiate it is cystic or a solid. Okay, and there are some other signs. They are classically uh, indicative of it can be a malignant swelling. Okay, so right now you try to remember ultrasonography will help us to know is it a cystic or a solid. Okay, and it is very helpful to differentiate benign and malignant lesions. That's all. Okay, CT MRI is an additional tool. Okay, to know the precise location. Okay, and it is helpful for to note the small swellings which may be missed during ultrasonography. Okay, and the important one is relation to adjacent important structures. It can be nerve, muscle, vascular. Why we should know about these? Of course, this sentence gold standard for assessing palpable, non-palpable lymph nodes. Okay, contrast will help us to know the vascularity. But why we should know about this? Second sentence, anybody? Suppose you are planning for a surgical excision. Okay, what is known as a resectability of the tumor? Okay, whether the tumor is resectable or not, and this will be helpful by knowing. Okay, whether the particular given mass is adherent to important vascular structures or not. Okay, muscles and nerve tissues. Okay, nerves. If it is quite adherent, then it may be going for a unresectable tumor. Okay, so that is about CT and MRI. Thank you. Any doubts you have got? Okay, most of the things we have covered it. Okay, fine. Thank you.
From 1 to 201 slowly. Sir will mark.
This is the continue. Okay, I'll be taking attendance. Okay.